The CTC4 program is the fourth program in the series of ambitious, meticulously planned and structured courses for palliative care in this country. It is arguably the best program running at the moment in the country.
In CTC1, that is called Cancer Treatment Center Program Cohort 1, we took 10 centers. 10 centers from all over country, but we miserably failed in 5 centers. When I was talking to Dr. Cynthia, I was telling that wherever the cancer patients are getting treatment, at least they should get pain relief. So that's why the name came Cancer Treatment Center Program. Obviously, I can say now we are not focusing only cancer patients. We are targeting all the patients in other area also. So maybe after some time we can change the name of this program, but right now this has become the Cancer Treatment Center Program. So we can call it Lien Collaborative Program or we can call it CTC program. But people here in India, they know CTC program supported by Lien Collaborative. India, it's a huge country of population of 1.36 billion. And to reaching a patient, those who are in the interior part of the country, it is not that easy.
I came to Kashmir to visit Sikkim's hospital and also CTC group at the medical college to get an idea as to how they are doing and how I can help with the nursing and with the home care.
Now we have started exploring this place, this dull area, because this is a marginalized area and these people need a lot of service here. They cannot come to the hospital on time, and we have cancer and non-cancerous patients over here. They're suffering and there are many other problems which we need to cater.
Now, some of these treatments must be done at the hospital, but some of these treatments can be very well done at home.
Because it's very difficult to get when it's winter time, so this lake has been frozen. So it's very difficult to grow the boats. If the doctors will come door to door, so it will be very helpful for them. So we need like this type of help in the lake.
They need a lot of support. For example, this woman maybe is going to be sent to one of the most expensive hospitals of India. But there are alternatives and we can help out. So we can all connect because we have many nurses, we have many doctors, we have many connections. It's also CTC. It's a gift of CTC. It's a gift of LMEC because we have spread. So we have a huge network. So we need to go to the little nooks and crannies. She's distressed because there's no father. She's distressed because she's a widow. She was kicked out. She doesn't look like it, but she's only 32 years old. They sold everything. There is nothing. So this is the heart of palliative care because this will make the communities know these guys will come and help. Everybody will help. And this will be a community that helps each other more than they already do.
Many initiatives have happened, many. After this training, I think we start searching what are the gaps in various centers because this was a uniform training and teaching which we were giving to all the centers. So that nurses of those centers should be trained enough to develop the concept of palliative care in their mind. Almost all CTCs are doing something. They are doing nurses workshop, nurses program, teaching program, training program or doctors training program. So a lot of good work is happening. This is the way we are developing and we are building our capacity.
40% of the patients die with severe pain, cancer pain patients, and 60 to 80% complain of inadequate pain relief by their physician.
Today's training program is that our doctors should get familiar with all about pain and palliative care so that they can go from here and try to implement it in their healthcare system. This was the first beginning that we are organizing at the divisional level, and now in second go we will go into all the districts. Those doctors who have got trained here, they will train the staff of their own hospitals. This idea is basically to provide them palliative care at their doorstep level, and And second thing, we are planning to introduce hospice or the palliative care in their home. So that is the third step. So we are working, we are trying to formulate how we can be more effective.
That doctor and that sister walked, won't believe, that just gives me a goosebumps. They walked for 12 hours to reach that mountain area. What they did is, they called me up in Jammu and we managed and planned the treatment and end of life care for the patient. I was taken up by Dr. Shubha Batakarpa CTC3 along with my 2 nurses from the hospital. And after completing my CTC3, the important thing is, it was very immediate after CTC3 that we could launch our first palliative care service center in J&K. It was because of their initiatives that we could really start up the palliative care services, and see now it has been incorporated as a national palliative care program, has started up in J&K. So definitely CTC has played the vital role, that is the backbone of the program.
So that's how we started, and the journey is still on. We are facing a lot of difficulties, but I think so together we can make it possible and make a journey successful. Very important thing that we learned during CTC is that a teamwork is very important. So it is with that concept in mind, in a team we will be able to deliver better rather than as an individual. So that concept of team building and then delivering was taught to us by CTC training. So that is how we have helped each other. We all belong to different hospitals, but we are working as a team together.
When I joined the CTC course, it was an eye-opener. I had more than 35 years of experience as an anesthesiologist. I really didn't know much about palliative care. There were doctors from all over India, from so many districts. Few were just physicians, few were from the surgery department. So they had different backgrounds, and the services they were getting in their hospital, in their workplace, were also very varied. You know, each team is assigned mentors in the CTC program. We had very good, excellent mentors.
During CTC training, I feel more empowered and learn about the
different type of
communications, and we improve our communication skill and end-of-life care symptoms. And we learn about the pain and other symptoms easily. So we empower after CTC training, and we easily handle the different type of symptoms and their management.
And our end-of-life care counselings and giving good dignified death to a patient is now not a grey area for us. We can do it more confidently. And I think we are helping our patient to improve the quality of life of the patients and the relatives too.
One word: enlightening. Health is a total state of emotional, physical, mental and spiritual well-being. Palliative care gels all that into one. And CTC helped us a lot to do it because it gave us the wings and it gave us the training. I could check on my communication. We could know the methodical way of procuring morphine. So we approached the government through the right way. And second thing was that I could take care more of the symptoms. Pain I knew how to take care, but other than pain was a limitation. And then we requested the administration to increase the number of beds in our wards, and then I got a team with CTC. Initially I was working alone, then I had Dr. Sunil, and then fortunately we could convince the administrators to give us nurses. So the working becomes very efficient and the work sharing is also easy.
The other advantage of the Lien Collaborative program is it can work with governments. And so you need that almost tri-party approach with government institution leaders and then master training of clinicians to then deliver palliative care that's consistent within their healthcare perspective. So those gaps, I think, are very much what we've done by doing a scoping visit in a new country that we're planning to go in, to understand the healthcare system, to understand what the gaps might be, what the needs are, and then sort of changing our approach to meet those needs.
Since CTC3 I have been associated, and it's been a pleasure to be associated as faculty because I always felt the need, and having been in the armed forces for almost 30 years now, I've traveled across India and I have been in the remotest parts of India and having to watch patients and armed forces families especially where there is no access, no concept of palliative care in the periphery. So trying to make that change, being part of that change, what CTC program is trying to do is getting institutions from all over India and getting them to train their teams so that they can start OPD services, IPD services, home care, and also be part of the education. So it's a beautiful concept.
Bus. Team 1. Which was the first oral analgesic mixture? We have bettered ourselves over the last 5 years. We constantly learn from our mistakes, and we have published a paper actually on 3 CTC cycles. Every CTC cycle teaches us something. It teaches us something about our training, it teaches something about our mentorship, it teaches something about our hands-on. We always try to reflect and see what worked well, what did not work well, and what are the areas of improvement. And we adopt those learnings to the next CTC cycle.